Picking up on part two of suicide, we're going to look a little bit at the epidemiology and risk factors for suicide. And I had mentioned in the first video that overall the ability to predict suicide based on risk factors is actually really poor. So our ability as clinicians to use risk factors to determine whether or not somebody is at high risk of, say, completing or not completing or attempting, etc., is actually terrible. So one of the worst things that can happen to anybody in the mental health field or any psychiatrist is that they can have a patient that they've seen or say someone that they saw in the emergency department who said they were suicidal, but when you got into talking to them, it wasn't enough to meet, say, commitment criteria, and you end up discharging that person, and they come and then find out the next day that they completed suicide. It's a terrible, terrible thing, but at the same time, I'm not sure how accountable you can really hold people since we don't have great methods at this point and evidence-based methods for predicting suicide based off of these risk factors. But I will talk about the risk factors and which ones do have some validity. Okay? So one 5-year study actually looked at risk factors and found that there's a really high false positive rate. So meaning that suicide was predicted but did not occur. So there was a false positive rate of approximately 30%, suicide was predicted, it didn't occur, and also a high false negative rate for that matter. So the false negative rate was found to be about 44%. So suicide was predicted but did not occur. So again, point being is not very good at predicting it based on risk factors. Despite this data, so risk assessment is still an important factor in estimating risk, planning, interventions, and evaluating the patient's thoughts and feelings. So obviously, even though these things are not been proven to be very good, and maybe if you have a patient who's absolutely set on completing suicide, they will likely complete suicide, or they'll come in to see you for whatever reason. Maybe a family member brings them in, says, I think they're depressed, I think they're suicidal. And then when you talk to them and you get the history and you ask all the questions, they pretty much put on a very, very good show, and then they go home and complete, because this is a person who is absolutely set on ending their own life, and it's going to be very, very hard to change that necessarily, although we do the best we can, of course. So you want to assess, again, things like risk. You want to see planning. How far did they get with a plan? Do they have a plan even? Did they put the pills out on the table? Did they get a glass of water? Did they gather all of the things? Have they been researching the ways of completing on the internet? And what are their feelings? Are they depressed? Are they happy? Are they anxious? Etc. The best predictor of suicidal behavior, of course, is a history of previous suicide attempts. We know the best predictor of future behavior is to look at past behavior. So one of the questions you always want to ask any patient who says they're suicidal is, have you ever attempted in the past? And if they've attempted in the past, figure out everything there is to know about that previous attempt. How did they do it? Were they hospitalized? Did cutting their wrist require sutures? When they took that overdose of medication, did they wind up in the ICU? How much time did they spend in the hospital? Again, assess how serious the attempt was. Was it really, really serious, or was this like, I took 5 aspirin and went to sleep? That might not be as serious, although still concerning, but may not be as serious as someone who took an entire bottle of amitriptyline and ended up in the ICU for a week. That's a completely different story. So 50% of all suicides occur in patients who have at least one prior attempt. So you want to look for prior attempts. Bottom line is screen for prior attempts. Figure out all the details surrounding those prior attempts. And in the year following an attempt, there's actually up to 100-fold greater risk than the general population for these patients. Obviously in the United States, and there's tons of talk about this now no matter where you go, but firearms are the most common means of completed suicide, with suffocation including hanging is second and overdose being third. But of course the most lethal means you would imagine would be firearms or gunshots. So with that said, you can see that that's the most common way that people complete. Drug overdose is the most common method of failed suicide attempt. So basically, overdose doesn't always kill people depending on the medication that they use and depending on the amount, the doses, how much they took, etc. Suicide rates also vary widely among different groups of people. So gender, age, ethnicity, marital status, employment are all significant factors. And again, these are kind of the things we screen for, and these are some of the risk factors we look for. Of course, males are more likely to complete, females are more likely to attempt. Older age is a risk factor, and especially people who are older age who have chronic medical illness. Marital status, people who are divorced, never married, separated, etc., are at higher risk, and those who are unemployed or who have financial burdens are also at risk. Women attempt 3 times as often as men, and males, of course, are 4 times more likely to complete. The suicide rate actually increases with age, so contrary to maybe popular belief that the suicide rates might be more common in younger people, it actually increases with age. So 70% of the suicides actually occur in people over the age of 60. And again, I think a lot of that has to do with whether or not these people have formed, or created a life for themselves that they really enjoy. Are they having trouble with employment? Are they suffering from certain chronic medical illnesses at this point? And have they been divorced, etc.? The adolescent age population is another at-risk population, so 15 to 24-year-olds. They are also at high risk, with suicide being the leading cause of death among this group. So most people or most children and adolescents age 15 to 24 are actually relatively healthy. They don't have a lot of health problems. So obviously one of the ways in which you'd have people dying would be accidental deaths, such as say car accidents, etc., or deaths by suicide. So this age group is definitely at risk and one that you want to screen for. So the highest rates of suicide are actually among ethnicities, is among Caucasians and Native Americans. Individuals who are, of course, divorced, widowed, live alone, are unemployed, or who have financial difficulties are at higher risk. So one protective factor, and probably the most important protective factor in my opinion, is that if you have children under the age of 18 in the home, this decreases the risk, as does, of course, good social support systems. So social support being family members, friends, people you can rely on to help you when you are down. But children under the age of 18, I think, is extremely important because children under the age of 18 really can't take care of themselves. I mean, arguably these days people in their 30s can't take care of themselves, but in particular, children under the age of 18 really can't take care of themselves without their parents. So this is a really, really important thing to ask about. Since 2003, there's been an increase in active duty military suicides. Well, that makes sense because that coincides with some of the wars that we've been in recently, and the fact that a lot more of our military personnel have seen combat. So there's an 80% increase, and rates surpass that of the civilian population. So of course, people who are active duty military, those who have seen combat, who might be suffering from things like PTSD, or who have lost, friends and such in the war, are definitely going to be at risk. Nearly 70% of soldiers who complete suicide have been in combat. So again, that's an extremely important thing to ask for if you get a vet and you're dealing with a vet. Make sure you ask them about combat. Figure out if there's anything going on there. And they're usually younger people. And some of it is hypothesized that we have a desensitization to violence and increased stress and changing demographics of wartime recruit. But regardless of what the whole fact is, I think anyone that's seen combat is certainly going to be at risk. So mood disorders, major depression, bipolar disorder, found in 50% of complete suicide. Again, I said 90% of people who complete suicide have at least one psychiatric diagnosis, so look for those psychiatric diagnoses. The presence of severe anhedonia, which is loss of interest, anxiety, panic attacks, insomnia, impaired concentration, alcohol use disorder all increase the risk. In particular, alcohol use disorder and drugs, because with alcohol use disorder, the person will be less inhibited. So they'll be essentially disinhibited and more likely to do something to themselves in this case. And also another independent risk factor, this is a very, very important one to ask for, is hopelessness. So if you should actually ask outright, do you ever feel hopeless, like things will never change, like you can never get out of this situation? And if you ask that question and the answer is positive, then they have an independent risk factor. Hopelessness itself is independent of mood symptoms, is a risk factor for suicide. So independent of any depression, anxiety, etc., just the feeling of hopelessness alone, or the thought of hopelessness, is a very powerful risk factor for suicide. Obviously, anxiety disorders and panic disorder and PTSD may play a role in 15 to 20% of suicides. Substance abuse, including alcohol, polysubstance use, also plays a role, about 25% of suicides. Suicide risk is greatest later in addiction, with it peaking at 9 years after first use. So again, because again, I think you develop that sense of hopelessness at that point. If you've suffered from addiction for 9 years, you're not getting any help, then obviously, you're going to feel more hopeless and more like there's no way out of this situation. The presence of major depression, chronic medical illness, which I've mentioned previously, loss of close relationships, again, goes to social support, all significantly elevate the risk of alcohol and drug use. All elevate risk, and alcohol drug use also impairs judgment, and again, I said increase in this impulsiveness. So when you're disinhibited, you're more likely to be impulsive, and you're more likely to do something to harm yourself. Psychosis also contributes to approximately 10% of suicides, but psychosis not as much as people might think. Patients with schizophrenia who complete, they're likely to be newly diagnosed, so these are actually all important risk factors for suicide in schizophrenic patients. So patients with psychosis look for newly diagnosed, young male with a very high premorbid functioning and good insight into the illness, because this person is going to realize when they are diagnosed that this is kind of a lifelong illness. It's progressive. It doesn't ever really go away fully, so they're going to be dealing with this over time. And if they have good insight, if they had good premorbid function, they're likely to decline in their function and realize that this is a bad situation. So that's also important. Also, things like akathisia and abrupt discontinuation of antipsychotics increase the risk of suicide as well. So think about that. Command hallucinations are another thing we screen for. So command hallucinations, patients commonly come in and say, voices are telling me to kill myself or hurt myself. You should always screen for that in any patient who presents with symptoms of psychosis. Also, obviously, personality disorders fit in there. Particularly, I'll mention borderline personality disorder and antisocial personality disorder. They contribute to approximately 5 to 10% of suicides. These patients tend to be impulsive. They often do, especially the borderlines, tend to be impulsive. They often have they do life-threatening manipulative acts. So sometimes this is referred to as parasuicidal behavior. And what can happen is, if you're too dismissive of this, and if you don't give it the proper attention it deserves, these people end up completing inadvertently. They're not necessarily trying to kill themselves. It's more of an attention-seeking behavior, but they do so kill themselves anyway because of the lethality in which their attempts are. Medical disorders, obviously severe chronic disorders, are associated with increased suicide risk. So 40% of patients who complete suicide have some kind of medical disorder. And some of the more common ones are things like renal failure on dialysis, HIV/AIDS, lupus, epilepsy, multiple sclerosis, Huntington's disease, and chronic pain. A family history of suicide also increases risk by twofold, as does family history of psychiatric illness. And early childhood, including prenatal separation, also confers increased risk. But so chaotic childhood, and parental separation also confers risk. But the most important thing you want to know there is that for family history, always ask the patient, is there any family history? Has anyone in the family ever attempted or completed suicide? Just ask that question real simply, and you'll get a response, and they'll think about any family members that have. And there's risk. Again, twofold higher risk for family members who have attempted or completed. And I'll save the neurobiology for the next video, so I'm going to probably stop right there. I know this is a lot of information, but the epidemiology and risk factors plays a huge role in our suicide assessment, so it's extremely important that you remember some of these things for the future.